ER nurses shrank into the background of the room, more than happy to cede their roles to the NICU team. 250-pound adults with heart attacks were their daily fare, but a micro-preemie, a baby that with a palm of a hand as big as a dime, was nothing they knew anything about. As I prepared to intubate the baby, an ER nurse asked me, "Doctor, what's your name?" She was the self-appointed scribe for the Code Pink, and she would record every detail for later scrutiny in monthly morbidity and mortality meetings of both the ER and the NICU. If I made any mistakes, they would be documented, analyzed against national performance standards, and brought to my attention for correction in the future. Hall, I replied, never taking my eyes off the baby, whose heart rate was dangerously low at 50 beats per minute, H-A-L-L. Out of the corner of my eye, I noticed several teary-eyed people huddled together, looking through the glass door of the trauma room. I reached over and yanked the curtain closed. The baby's head was no bigger than a lemon, and his tiny mouth barely admitted my laryngoscope. The light on the end of the instrument illuminated his white vocal cords, and thankfully I was able to slip a breathing tube into his windpipe on the first try. The respiratory therapist inflated his lungs, and immediately he began to turn pink. His heart rate did not respond, however. "Let me have some epi," I said, guessing the dose based on his estimated weight of just over a pound. Courtney handed me the syringe, and I squirted the medicine down the tube going into his lungs. I quickly announced that the epi was in, so it could be duly recorded with a timestamp. Meanwhile, I scooped the baby off the sweatshirt brought from home, and Courtney took his temperature. When she announced it was 94.5 degrees, I scrunched a pink and blue striped cotton hat on his hairless head to warm him up, noticing as I did tiny eyelids as tightly sealed as those of a newborn kitten. The minutes ticked away as we worked on him, and soon 5 of them had passed. It was time for another dose of epi. I repeated the dose, but the baby still didn't move. His little popsicle stick legs lay limply in front of him. A nurse I didn't know continued CPR, but I couldn't have picked her face out of a police lineup if my life depended on it. I opened my procedure tray, and Courtney struggled to keep up with my demands for instruments while I fought to stay one step ahead of her. I dabbed a bit of antiseptic solution around the base of the baby's umbilical cord, tied it tightly, and sliced it off with a scalpel. I bent over the baby with 2 tiny sets of forceps, 1 in each hand, identifying the vessels in the cord marked by pinpoints of dark blood. My luck held. Within a minute, I successfully snaked tiny catheters into both the umbilical vein and artery and asked for another dose of epinephrine. This time I infused the drug through the IV line, and seconds later, the baby's heart rate was over 100. I ordered CPR to stop. Next, we poured a dose of surfactant down his breathing tube, and the white milky liquid slithered into his lungs, allowing for better inflation of his air sacs, the alveoli. A few minutes later, the baby started to breathe on his own. This was a major milestone. We brought the baby back to life within 20 minutes of his arrival in the ER, but his NICU journey was just beginning. So that story kind of illustrates how we have emergencies all the time in the hospital, and sometimes we even go to other hospitals for emergencies. And we walk in and we may not know anyone in the room. Hopefully we have one of our nurses or somebody that we do know that we feel more comfortable that they'll know what we want. But often in medicine, in the operating room, in the emergency room, teams of doctors and nurses are there who've never seen each other, and they have to figure it out on the spot and work to do their job and help the patient. So that's one of the really remarkable things about medicine, is that we train for these emergencies, and we train with all kinds of people and in our own areas, so that when we all get through them together, we can do it.